There are growth lines in the head, and when any of these growth lines are fused, it is called as craniosynostosis.
They may have a severe loss of visual acuity or even become blind. Those surgeries are either life-saving or functional saving.
Hi, I'm Dipesh. I'm a craniofacial surgeon interested in clefts and craniofacial deformities. That is my chief area of expertise. I work at the Bhagwan Mahaveer Jain Hospital with Smile Train and other NGOs, allowing this care to be provided to children from all socioeconomic status. We can offer this free of cost and to those who can afford it as well.
So hi, my name is Hossein Khonsari. I work as a craniofacial surgeon in Paris, France, in Necker Hospital, where we have the National Reference Center for Craniofacial Conditions for the whole country. I'm specialized in the management of syndromic craniosynostosis, among other craniofacial malformations, and I have been fully trained in Paris in this center, which is probably one of the busiest and also the most historical craniofacial centers in the world, where several of the techniques that are used worldwide have been developed and perfected over the years by the previous major names who worked there. Dr. Marchak, who was one of the pioneering plastic surgeons, Professor Régnier, the neurosurgeon, and then the next generation with Dr. Eric Arnaud, who then trained me.
So craniosynostosis is when there are growth lines in the head, and when any of these growth lines are fused, it is called as craniosynostosis. Growth line going from front to back, and if that line is fused, the head shape deforms and the front part becomes bossed, the back part becomes bulleted, so you get a dolichocephalic head. The lines in front are fused, one of the line is fused, you get an asymmetric head. So based on the growth line that is fused, then they will get a abnormal head shape. And this is a birth deformities, and this has to be identified early because you can make changes if it is presented within the first 2 years of life. It gives the maximum benefit for the child.
Yeah, so the key element with craniosynostosis and craniofacial surgery in general is that it's not just a surgery for making the look of the kids better, it's a functional surgery. So in many of those patients, if they don't benefit from the right treatment at the right time, they'll have definitive issues that we won't be able to treat later. For instance, they may have a severe loss of visual acuity or even become blind. They may lose lots of their cognitive abilities. They may have motor anomalies due to associated spinal issues. Those surgeries are either life-saving or functional saving. Have a unit that manages to perform those surgeries at the right ages is really a critical matter for those kids. And to be very crude and direct, most of those kids won't die, but they will become highly disabled. So they'll add extra issues in their management for their families, for the society. So it's really a critical point to put them in a situation where they can integrate as good as possible into society and grow with the biggest possibility to be as normal as possible. Because when they have the adequate treatment, their chances of becoming what we could call normal kids or nearly normal kids is quite high. That's why it's really not a luxury to have those expensive surgeries performed in India. Those surgeries are very complicated to perform outside of India for those kids because they require long hospital stays, and it's hard to imagine a family from Bangalore moving to France for 6 months, a few times over the growth of the kid for the 3 or 4 or 5 or 6 procedures that the kid will need. It's not reasonable. So that's why the competence of craniofacial surgery it's mandatory that it's transferred locally, and it's really a matter of saving the future of those kids.
If the child is presented to us around 6 months of age, we sometimes just follow them up to a point where they are 10 to 15 months of age, and we do a definitive formal correction. That means in one surgery the head is corrected. If they are non-syndromic craniosynostosis, oftentimes it is the single surgery that they will receive. But if they are syndromic, unfortunately they may require multiple surgeries. So every patient receives a standard evidence-based care wherein we look at the child's presenting age and the symptoms that the child has due to the craniosynostosis. We have enough evidence to suggest that it is not just a cosmetic correction, it is a correction wherein you have functional benefits after doing the surgery as well.
Yes, so craniofacial surgery exists for now over 50 years. But the main issues with this kind of surgery is that it's a surgery dedicated to rare diseases. So you need a whole system behind the surgical department for it to be efficient at the level of a country. Strong, organized system to bring the patients to major centers, and then within those centers you need quite extensive MDTs. And that's probably why there are so few functioning and busy craniofacial centers around the world.
We also look after the post-operative care. So what tends to happen, children with syndromic craniosynostosis, at least 60 to 70% children have a chance to have a normal life. Smile Train has allowed us to have a very large team. We have the speech and language therapist, a psychologist, an orthodontist, a pediatric dentist, a nutritionist working closely along with the surgeons. And we also have pediatric anesthetists who allow us to do these procedures safely. With this multidisciplinary approach, with the help of the other specialists involved in the care of these children, we can give them the best chance to integrate with the society. It's just probably from the try to give the best care to your patient. Think of the patient as your own, and with that we have offered patient-centric care, which is intricately woven with evidence-based. And this is something that when Dr. Krishnamurthy started this unit, instilled in all of us that we have to have a patient-centric approach. I think we are kind of trying to remain honest to our work. And when we keep honesty as the first aspect of our care, we allow inputs from multiple units around the world to help us provide this care to our patients.
So I think the collaboration could be based on at least three aspects. So the first one would be to have more trips of my team to Bangalore, and then probably the Bangalore team to Paris, to increase the personal training of the practitioners, which is, I would say, the easiest part of the job, because we are all trained surgeons, so the progress is quite straightforward if we get really involved into this field. So this is not a very worrying point. Then the second point would be maybe to work with the way rare disease management is organized in France, to try to replicate part of it in India. I don't have any understanding of the Indian system, but I believe that if we want this whole system to work, we need at least to introduce some principles of awareness and recruitment, and teaching to the midwives and teaching to the maternities and everything that's done for the rare disease management in France, to bring those principles to India. So that would be the second step for the logistics of the rare disease management at the level of the region or even the country. And then the third aspect would be an academic collaboration with research. India has many talented students, so we could imagine to have an academic collaboration and send some students to France for extra training, and or have long distance projects where local students here would work online on various research projects based on sharing some clinical data, and that would add a brick to our collaboration by the production of some scientific studies.
So a lot of times people ask us why we do what we do, and I really love the work that I do, because there is this element wherein the child is at the apex, the parent and the caregiver form the base, and because the child requires care at multiple stages, from the time he is or she is born to the time they become an adult, we have to be there at the base, giving them a strong foundation on which they can try to express their full potential.
So based on this very short experience that I had in India, just over a week, what I can say is that it's quite realistic to expect to build a craniofacial unit here in Bhagwan Mahaveer Jain Hospital in Bangalore, because the facilities are quite similar to the facilities where we work in France, and the training of the doctors, the current training of the doctors, and the organization of the hospital allows to expect to duplicate the structure of our unit in France in Bangalore in a prospect of 3 to 5 years, with exchanges of competence, visits in Bangalore and in Paris, and also scientific work. And this is why this project is so exciting, because the realistic prospect of building a craniofacial unit is quite clear, and we can expect to obtain practical results in the near future.
The Bhagwan Mahaveer Jain Hospital has been very supportive in our department's existence in the last 19 years, and their motto is in sync with our motto, that is caring with compassion. And this motto allows us to give the best to our children so as to make sure that they can integrate in the society and express their full potential.